Okay, so now we're going to run through some of the differential diagnoses of the posterior ankle, because there are actually quite a few. It's not just the Achilles tendon that's back there. So we're going to start with our garden variety, mid-portion Achilles tendinopathy. And remember that Stacey described it as two fingers, sort of either side. They tend to pinch their mid-portion Achilles. They're provoked by those energy storage loads, so our running, our walking, sort of more change of direction. And moving on from that, we also have our insertion. So insertion tends to be with one finger, usually on the lateral aspect of the calcaneus because it's a slightly bigger bump. And someone with insertional Achilles will also report that compression load and the combination load. So the compression load is things like, it's worse when I stretch, it's worse when I'm in bare feet because I get into compression earlier. In the gym, they might be worse with exercises where their tibia goes over their ankle. They will often report being better in shoes because they're in less compression. So there are two tendinopathy diagnoses of the Achilles, our mid-portion and our insertion. So now we're going to move on to some of the other things. Remember we talked about the peritendon, and the peritendon, the clues you'll get in the subjective assessment relate to load, it's moving through range, it's pain that doesn't warm up, it's pain that gets worse the longer they go, and move that peritendon over the sheath, that peritendon over the tendon. They might have night pain as well as a bit of a flag. Their pain is quite diffuse, so they'll actually show you the whole tendon. You might remember at university they said Achilles tendon pain is 2 to 6 centimetres above the calcaneus. It's because people have different length Achilles. It's not pain spread. Tendinopathy is really focal. People can point to it with 1 or 2 fingers. As soon as people are diffuse or vague or they're finding it hard to find, I want you to have your antenna up for peritendon. So in addition to your subjective clues that you'll get, in the objective, you'll see that diffuse pain provoked by low tendon load and not necessarily provoked when you go into the energy storage loads. It's more about how much range they're going through. My final tip for picking up peritendon though is from Dr 𝘼𝙘𝙝𝙤𝙆𝙝. Keep your stethoscope from university, you pop it over the tendon and you get them to plantarflex and dorsiflex their foot, and you'll actually hear the crepitus. So you can put it over any of your superficial tendons. So your Achilles tendon, it works well. You can listen to your FHL and also your tib post tendon as well. Remembering the reason why that's important to differentiate is if Stacey has a peritendon issue, we don't want to give her calf raises. Movement is her provocative load. So it's a different rehabilitation. We need to start with reducing any through range work, and these are also irritated by heavy isometrics that bunches up the peritendon, so that can be another little clue if they've tried any gym work prior. Okay, so we've got our mid portion, we've got our insertion, and then we've got our peritendon. The other conditions that can occur in and around the posterior ankle also relate to plantaris. So plantaris pain is usually on the medial side, well it is on the medial side, and it's usually quite high. So it's when people don't point to mid-portion, they're very, very medial, and often, as I said, it's a little bit higher. So your plantaris is a small muscle and a long tendon that comes down. Its interaction with the Achilles can vary. So as I said in the subjective, it can be inside the same sheath as the Achilles. It can even just insert on its own into the calcaneus. But if it's involved, people will have this medial sided pain. They might have a friction between the plantaris and the Achilles, so you might hear some crepitus on your stethoscope, but clinically they'll report being provoked in dorsiflexion. The reason for that is the plantaris tendon is a stiffer tendon than the Achilles. So in dorsiflexion, it actually compresses your medial Achilles and provokes people's pain. So it's quite high, it's on the medial side, but it sounds more like an insertion. So what I mean by that is they're provoked in dorsiflexion, unlike your mid-portion. They don't care about being in dorsiflexion. So someone with a plantaris involvement, if they've been given calf raises off a step, they'll be worse because of the compression. They might also hate being in bare feet, which can be another clue for you. Okay, so we've got our mid portion, our insertion, our peritendon, and then whether or not you think you've got a plantaris involvement. There's a couple of other things back here. So the next one to consider is 𝑘𝑠𝑐𝑟𝑎𝑙 nerve. The 𝑘𝑠𝑐𝑟𝑎𝑙 nerve is on the lateral aspect of the Achilles. The way to palpate the 𝑘𝑠𝑐𝑟𝑎𝑙 nerve is to just pop them into passive plantar grade with your thigh, then with your fingernail, just gently flick over the 𝑘𝑠𝑐𝑟𝑎𝑙 nerve, which will feel like a piano string. It's very small. A normal nerve is not painful to palpate. So if your patient or athlete is uncomfortable, you need to think that the 𝑘𝑠𝑐𝑟𝑎𝑙 nerve is irritated. That could be something higher up the kinetic chain, it could be lumbar, it could be some sort of intersection. It might also be local. So if your tendon is swollen or the peritendon is irritated, you can also irritate that 𝑘𝑠𝑐𝑟𝑎𝑙 nerve. So you might need to decide you're going to manage it as a primary diagnosis, or you might need to just keep an eye on it. These people, and it's not very common, but I have seen them, you might get all the way through your objective assessment and they don't have pain. They don't have pain with hop. So then you might try things like calf raise off a step, or you might look at neurodynamic testing. You might sort of start to hunt down other differentials. So if I am confident after my load assessment, I don't worry about some of these other differential diagnoses. This is when I'm hunting. So if I get to the end of my load assessment and I'm not sure, I would get out my stethoscope, I'd palpate my 𝑘𝑠𝑐𝑟𝑎𝑙 nerve, and then I'd also look at the posterior ankle and the FHL, which I'll do next. So it's also important to make sure that conditions of the posterior ankle joint are not driving symptoms, and that can include posterior ankle impingement, but also the flexor hallucis longus tendon, which is usually a peritendon issue. So what I might do is actually just feel through the back of the posterior ankle, and I learnt this from Dr 𝘼𝙘𝙝𝙗𝙗. So it's essentially an overpressure into plantar flexion, but you're adding inversion and eversion to feel through the corners of the joint. The key times that can be really useful are if someone's referred to you with a perineal tendinopathy. Now you can get a perineal tendinopathy, but it's actually really uncommon. What's more common is that someone's had a big ankle sprain. They've not done very well because it was a big ankle sprain. At some point they've had an MRI, the perineals have lit up like a Christmas tree, and they've received an imaging-based diagnosis of perineal tendinopathy. The other thing that happens when you have a big ankle sprain is you get subtalar joint swelling. Now, any subtalar joint swelling is relevant because there's not very much space in there. The reason why this is problematic is the person that has the misdiagnosis of perineal tendinopathy was probably given TheraBand into their posterolateral corner for their perineals, exactly their provocative load. So what you want to do is just go back to basics, not allow anyone to carry their diagnosis, and just check out that posterior ankle, particularly that posterolateral compression. If that provokes their pain, they have posterior ankle impingement, not perineal tendinopathy. And what you need to do is a lot of retraining around calf and avoid that top range. So these would also be the people that say, I hate doing isometrics in full plantar flexion, because that's actually compressing the posterior ankle joint. So really listen to people during the exercises, particularly if they've been non-adherent or it's provoked them. You can get a lot of really valuable information. So tendinopathy is a rate of loading condition. So by definition, anything static or slow doesn't provoke the tendon. So if someone is provoked by isometrics or isotonics, you really need to reconsider your diagnosis. All right, so we've got our posterior impingement. Again, as I said, that's important not just post ankle sprain. The difference between an insertional Achilles, where you want someone to do their isometrics up really high, and a posterior ankle impingement is their provocative position. So you need to make sure that you're differentiating between the posterior ankle joint and an insertional Achilles, because you give very different advice. The next test we're going to look at is for the FHL. Now the FHL is normally a sheath issue, a peritendon issue. So we see it in dancers that go from big ranges of grand plie to point. So they go through a lot of range of motion. So it's usually the sheath and not a tendinopathy. And the way we assess that is to ask our patient, athlete or dancer to lie on their back for me, please. And again, I'm going to credit 𝘼𝙗𝙗𝙗 with the assessment for this one. So I'm going to bend that one up so we can observe our FHL really well. Now, can I get you to wiggle your big toe? Well done. A lot of people struggle with that. Good job. But that way I can feel that I'm actually on your tendon. I'm going to push against your big toe. You're going to point your foot and resist me the whole way down. So point, 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 push, 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 push. Good. Keep going. Excellent. Now I'm going to ask if you've got any pain. I'm also going to be feeling for crepitus. I can use my stethoscope too. If you point your foot all the way and now wiggle your big toe, your FHL in the tunnel is actually quite compressed. So both of those tests can be quite provocative, and you can feel that quite nicely through that gutter. One of the key differentials from insertional Achilles is actually the subcutaneous bursa, superficial bursa, calcaneal bursa. It's got a few different names, and it sits between the tendon and the skin. So it's not part of the muscle tendon unit. So in terms of its location, it's quite low. Sometimes you can see it. If it's irritated, it can sometimes be a bit red and a little bit swollen. So the superficial bursa is provoked by footwear. It can be compression of footwear or friction. So the reason we want to differentiate this from the insertion is people with insertional Achilles love being in their shoes because it takes them out of compression. People with the superficial bursa say to you, I can't wait to take my shoes off. And you can see them in combination, particularly if a well-meaning physio or podiatrist have given a whole lot of inserts for inside the shoe, can often push people up out of the shoe and rub on the back of the heel counter. So what you want to do for this person is you actually need to modify how their foot interacts with their shoe. One of the ways you can do that is to cut 2 felt strips or foam strips to go inside their shoe, either side of the superficial bursa, so that you don't have that compression or that friction. So that can work really well in footy boots, basketball boots, their sneakers, whatever they need. But clinically, these people will say to you, I prefer being in bare feet. Insertional Achilles will say to you, I hate being in bare feet. We need to pick these ones up because if we don't sort their provocative load or their footwear, we don't get anywhere. All the rehabilitation in the world won't help this person because this person does not have a condition that's part of the muscle tendon unit. So they're not helped by isometrics or isotonics. If they've been unloaded, they might need rehabilitation. But I always want you to think, how can I address the provocative load first? So the provocative load of the superficial bursa is sorting out their footwear. So you've got skin, bursa, tendon, bone, retrocalcaneal bursa if you're working your way in. So sort out their footwear and then see what else they need in terms of rehabilitation. The provocative load for your plantaris is particularly in positions of dorsiflexion. The provocative load of your peritendon is moving through range, so you want to take them off their cross training, their bike, their cycling, their swimming. The provocative load of our insertional Achilles is particularly dorsiflexion, but as well as that, pushing off from a dorsiflex position. And the provocative load of our mid portion is our energy storage or our spring-like activities. So we want to recognise the provocative load, remove it initially, but appreciate that's what we need to get people back to.